the lateral margin was still involved by the lesion. Now the plan for treatment was to do surgery for marginal clearance and eyelid reconstruction. So again, unfortunately, this patient did not come back for the scheduled surgery, and the marginal clearance has not been done, and the surgery has not been done. This is one of the cases that we would say that the management has been shaky. So what can we learn from this case, or what the things we can learn from this case, and have we learned lessons from this case? But before we go there, we can actually just talk about these eyelid swellings, because these are patients who presented with what the first surgeon and the second surgeon thought was a chalazion, but it turned out not to be a chalazion. So are there things that the surgeon or the doctors who saw this patient would have looked for to see that this is not a benign lesion and it looks like a malignant lesion? Yes, there are. And eyelid malignancies, in as much as they are swellings, there are some key features that we look for to tell whether it's an eyelid, it's a malignancy, and you can tell it apart from can separate it from a benign lesion. First of all, the margins of the lesions are usually irregular. Remember, chalazion usually has a round shape, very clear margins. Nodularity, the lesions tend to be the nodules tend to be, they used to be more multinodularity. The nodules tend to be more. Remember, a chalazion can look like it's multinodular, but remember those are usually multiple chalazions, and each multiple chalasia, and each chalasia can be palpated in most cases separately. So that is another way of trying to differentiate. The other thing, as you can see in this image here, is this image. You can see destruction of the lid margin. How is the normal lid margin? Remember, it has a sharp posterior border and a curved anterior border. That border, you should always look for it if you see a lesion. If that border, the contour of that border is damaged, then that is always a suspicion of a malignancy, like you can see in this picture. Again, loss of lashes, that is very well demonstrated in this picture. Loss of lashes around the lesion, that is a very pointing thing towards a malignancy. Telangiectasia, that is the dilated tortuous vessels. Those are very key in malignancies, especially for basal cell carcinoma, as I'm going to explain later. Recurrence after surgery is another key pointer towards a malignancy, like we have seen in that case. So when you talk about those malignancies, what are the common eyelid malignancies that we see in our setting? The most common eyelid malignancies that we see in our setting is squamous cell carcinoma, basal cell carcinoma, sebaceous gland carcinoma. Squamous, in our setting, among the 3 common eyelid malignancies, these first ones are the common 3 malignancies. The most common is a basal cell carcinoma, followed by sebaceous gland carcinoma, followed by a squamous cell carcinoma. In the white population, the basal cell carcinoma is the most common malignancy of the eyelid. In Asian communities, sebaceous gland carcinoma is the most common. But in our setting, in Black African population, the squamous cell carcinoma of the eyelid is the most common carcinoma of the eyelid. Others that you can see is melanoma, which are very rare. I've not seen one in our population. Kaposi sarcoma. I have seen a few Kaposi sarcomas. They were common before the advent of use of antiretrovirals in HIV. Adenocystic carcinoma, a reported case that we have reported from Kenyatta National Hospital, very rare. Metastatic lesions to the eyelid are also very rare. So let's talk about, first of all, the common lesions that we talk about. Squamous cell carcinoma, as I said, is the most common in the Black populations in Africa. It can be ulcerative or nodular. if it is ulcerative, if you look at the margins, the borders are usually elevated, but the base is usually red. The lesion is usually very destructive. You can see the destruction of lid margin, the destruction of the loss of lashes. That's what I discussed before. Of course, the risk factors is fair skin, so you'll find it common in white people living in, especially in areas like Africa, in tropical countries. Age, of course, is common in higher age. There are reported cases of it being more common in HIV patients, but this is more of a squamous cell carcinoma of the conjunctiva or SSN. Other patients with the genetic conditions that can predispose a patient to squamous cell carcinoma include xeroderma pigmentosa, which we have seen cases in young patients. Albinism, we have seen squamous cell carcinomas and basal cell carcinoma in patients with albinism. The lesion can spread locally, it's very aggressive locally, but cannot also metastasize through the lymph nodes or through lymph nodes. Hematogenous spread is, I have not seen a case, and I have not seen it's not reported. On the other hand, basal cell carcinoma is the most common type of eyelid malignancies, as I already said. Typically presents with a multinodular lesion with a center which is ulcerated. This is what is called a rodent ulcer. Telangiectasia, you can see in this picture. I'm not sure whether it's clear in your screens that you can see blood vessels that are crisscrossing. That is typical of basal cell carcinoma. It mainly affects the lower lid, just like the squamous cell carcinoma also mainly affects the lower lid. Usually spreads locally and no reported distant metastasis. Again, risk factors, race, age, and other genetic predisposing factors like xeroderma and albinism. So sometimes it's difficult to differentiate between these two, squamous cell carcinoma and basal cell carcinoma. Is it usually, it doesn't matter so much if you can't get the difference because most of the treatment is the same. Squamous cell carcinomas are usually fast growing, and the basal cell carcinomas are a little bit less slowly growing. Squamous cell carcinoma tend to ulcerate early, and the ulcers are usually larger with a red center. Basal cell carcinomas are multinodular to start with, but gets a central depression, which later becomes ulcerated. The boulders in squamous cell carcinomas are firm, elevated, but pearly shiny in a basal cell carcinoma. Squamous cell carcinoma tend to metastasize to lymph nodes and also have a perineural spread. There are no distant metastasis in basal cell carcinomas. I've already mentioned about the base in a basal cell, in a squamous, which is usually tends to be fleshy and easily bleeds. For basal cell carcinoma, is not freshly red as squamous cell. It rarely bleeds, and the vessels are usually crisscrossing the lesions. If some cases of squamous cell carcinoma are nodular, and in that case, they are typically there is a typical hyperkeratosis. So it looks so much, there is a lot of scaly lesions on the surface, which is not there. Remember, basal cell carcinoma tends to be shiny. Usually, we don't get a lot of surface vascularization in squamous cell compared to basal cell carcinoma, which usually has surface vascularization. So those are the differences between the two, which are usually some cases, especially large cases, the difference is not clear cut. Sebaceous gland carcinoma, on the other hand, is rare in our setting. It's very malignant and potential lethal, which usually occurs in the upper eyelid. It arises mainly from sebaceous glands, of course, commonly from meibomian glands. And you remember there are more meibomian glands in the upper tarsus and bigger, of course, because the upper tarsus is bigger, almost double the size of the lower tarsus. So they're more common in the upper eyelid. Other glands of Zeiss can be affected, caruncular glands, and even the skin of the eyebrow, the sebaceous glands around there, they can arise, but mainly from the meibomian glands of the upper tarsus. That's why the lesion is usually more common in the upper eyelid. Commoner again on female at older age, but it can occur in children. I mean, younger individuals who have been exposed to periocular radiation. Radiation is a risk factor for most. As I said, this tumor is common incidence in Asia and North America. The typical thing about sebaceous gland carcinoma is that it really can mimic many conditions. In our case, you can see it mimicking chalazion. It can also mimic chronic blepharitis. It can resemble still squamous cell carcinoma and basal cell carcinoma, superior limbic keratoconjunctivitis, and sometimes ocular cicatric or pemphigoid. That is, it can mimic chronic conjunctivitis in some cases, sometimes even with skip lesions. In our setting, again, remember this is can be confused with a chalazion. But remember, even if it looks like a chalazion, if you look clearly, you can tell keenly. You might be able to tell that this is not the typical chalazion that you see. Because it's different. And the difference between this lesion and chalazion is that this lesion usually tends to be multinodular, poorly defined, irregular, sorry, not full, usually well defined, but irregular in shape. And when you got the eyelid, you usually should see the yellowish multinodular lesions. Most of the common case, the management of ocular malignancies, the common management is surgery. There are two main types of recommended surgeries for the eyelid malignancies. One of them is Mohs microscopic surgery. In most microscopic surgery, the lesions, the Mohs surgeon is the one who excises the lesion. They remove tissues. They can remove the big lesion, but the margins, they keep removing the margins and freezing them and examining them under the microscope to see whether the margin is free of tumor. They do that until they get a free margin. And then after that, if we get a free margin, then the reconstruction is recommended. This kind of surgery is preferable because it conserves tissue, but it is difficult to perform. And most of the times in our settings, we are not ready for this kind of surgery with the microscope and freezing. Most centers, what they do is frozen sections of the margin. That is the main lesion is excised in total. Then the tumor's margins are excised and examined and frozen, and they examine under a microscope. If the margin is positive of tumor, then more margins are excised until there's free of tumor, and then reconstruction is done. This examination is done within the same day, such that a patient excision is done, margins are done, and then the patient waits in theater for the frozen section to be done and to be examined under the microscope. The problem with that is that there are very few hospitals in Kenya that have the setting of frozen sections. And in that case, this procedure is not is not possible in most of the hospitals that we work in. So what are the kind of things that what are kind of strategies do we use in the absence of these two very good surgeries that we are not able to do in our hospitals? I'll explain to that because using the cases that I've managed, a few of the cases that I've managed, how we have been able to circumvent the challenges that we face in our hospitals for the benefit of our patients. Let me go to the second patient. This is a patient who came again with a recurrent right upper eyelid swelling. This is after surgery for calazion was done, INC was done. The good thing is that the surgeon for this case realized that this does not look like a proper, the real INC. Remember, when you're doing an INC, the liquid, I mean, the what drains there is thick fluid or liquid, I don't know what you call it. But in terms of this sebaceous gland carcinoma, the friable tissue that come out, so the surgeon was keen enough to take the specimen for histology, and a diagnosis was made was squamous cell carcinoma, which probably could come in to think about it. The diagnosis was wrong, but the pathologist could pick that this is a malignancy, and that is the most important thing. So when the patient presented to us in Kenyatta National Hospital, this is how the patient looked like. Upper lid swelling, looked well defined, non-tender. If you felt the margins, they were irregular. Sometimes people could be tempted to think that is this the extent of this lesion, but you'll see that is not the extent of the lesion when you avert. The lid margin and the lashes were normal, which is initially for the sebaceous gland carcinoma as opposed to squamous cell carcinoma, the lashes and the lid margin could be normal. Once you avert this lid, you can see this is bigger lesion that we thought before. It's nodular. You can see the nodular areas with the yellow lesions. This is typical, and you can see the dilated blood vessels. This is very typical for a sebaceous gland carcinoma, and that is the diagnosis that we maintain going forward. So what is the plan of management? Of course, a wide excision and reconstruction. So the patient was taken to theater where a wide excision, you can see it where it is marked, way beyond what you could see beyond on the surface, because this is the inner layer of inner lesion is wider than what you can be from the surface. So now what I usually do is that because you don't have the most microscopic surgery procedure, what I usually do is before I go in for surgery, I discuss with a pathologist we send the specimen immediately to the pathologist after excision, and they start the processing. If you do that, then you can get an histology report within 4 to 5 days. And then you can go in before the tissues fuse. What I do is I just do temporary closure of the lesion to avoid exposure keratopathy. You just suture the lid margin to the remnant of the upper lid, take the patient back to the ward. I don't discharge this patient. They may decide to disappear like the other patient disappeared. Then wait for 1 week, for 5 days, 4 to 5 days. In our case, because I do my surgeries on Fridays, I wait for the whole week. And by the end of the 1 week, then the histology is ready. In our patient, by the end of 1 week, the histology results were out and confirmed sebaceous gland carcinoma as we suspected. And the margins, fortunately, were free of tumor, so we were ready to reconstruct. So we took the patient back to theater. This patient had a more than 90% defect, so a Cutler-Beard procedure was of the Cutler-Beard procedure of the upper lid was done. I think this photo is verted. This is the lower lid. This is the upper lid. This is the bridge. So the Cutler-Beard, the borrowed tissue from the lower lid is, as you can see, very large tissue. Cutler-Beard procedure is a very good procedure because you reconstruct the anterior lamella and the posterior lamella in the same setting. In that case, it is an easy procedure to perform. So the patient currently, Cutler-Beard procedure was done, and the patient is awaiting the second procedure of separation of the lesion. So this is a case that as we managed to perform proper good management in that case. So I will go to another patient who I'll call patient 3. Patient 3 is a 70-year-old patient who presented. I saw this patient in an outreach outside Nairobi. This is a patient who presents, is a 70-year-old patient, male patient who presented with 1-year history of right eye swelling. The swelling was painful and bleeding on and off. He had a history of trauma of the other eye, the left eye, and the vision was 660. Had a disorganized globe after surgery, but he could still see through that eye. But the better eye was the right eye, which he could see 612. The eye which was affected, he could see 612. Fortunately, he had done an histology before, incision biopsy had been done before, and the confirmation of a squamous cell carcinoma had been done. So the patient came for that camp that I was hosting and for further consultation. So when the patient came, we saw a patient with a lower lid lesion, which was ulcerated. It was the whole extent of the lower lid. The lid margins were totally damaged. The lesion was extended to the medial canthus in a big way, and also on the lateral canthus was also affected. So this was quite an extensive lesion that had damaged the whole of lower eyelid and extending to the canthus. The lesion had a red base and areas of infection, and it was very friable. So, of course, as I said before, this is typical of a squamous cell carcinoma of the lower eyelid. The lymph nodes were free, but there was no lymph node involvement. This was a difficult case for us because of course, in the setting, the patient had come far from even the hospital had gone for outreach. So the following marginal clearance, this was an outreach. So this patient, referring this patient to Nairobi was difficult. The patient could not even afford the fare. Again, marginal clearance and waiting for 1 week, like I did for the other case, was not possible for this case. Histology in peripheral areas takes longer because the specimen has to be taken all the way to Nairobi, or in that case, the patient was in Kitui to Machakos. And again, now this case reconstruction is a nightmare because this lesion is very big. So what did we decide? What we decided to do is to do with what we can do. We excise the lesion, excising the lesion and reconstruct without histology. This is the best thing we could do in our circumstance. But now that brings us even a bigger challenge, because if you want to excise and reconstruct without an histology, then it means you have to really get a huge margin beyond the lesion. That means that your defect is going to be much larger than before, than if you were to have an advantage of histology. So this is what we did. We did a very wide excision of the lesion, way beyond the lesion itself. And this is what we are left with of the upper lid. It is just a 2/3 of the lid that we are left with. And to reconstruct is that presented ourselves with our reconstruction nightmare. But there is always a silver lining in every disaster. This this small lid, 2/3 of the upper lid, has a levator muscle. So that is a very good thing to think about, because it means if we do a reconstruction, probably this patient might be able to lift this lid, even if it's a few millimeters, and open and clear the view for this eye, because this is a better eye. So that is one of the things that we're talking about. And of course, there is a bit of conjunctiva which can be shared to cover the lid and to line the upper lid. And that is what we did. We averted this lid as if we are doing a Hughes procedure. Made an horizontal incision, pulled the conjunctiva, and sutured it to around the lower margin, to the tissues around here. That is the lining of the conjunctiva that will be able to protect the cornea of this patient. So the rest, we had to try and mobilize we had to try and mobilize as many flaps that we could. As I said, we managed to get a small conjunctival flap to cover the eyeball. We managed to get a glabellar flap to come and cover the medial defect. We managed to get a nasolabial flap. The good thing again is this is an old patient. The tissues are loose. So in an old patient, you can do so many flaps because the tissues are totally loose. So we managed to get a glabellar flap from, not glabellar, nasolabial flap, and also managed to mobilize tissues and skin from the temporal side to cover the temporal defect. So this is the final outcome of the reconstruction that we managed to do. This patient, as I said, we are seen in an outreach, so we had to go back for another outreach 2 months later. And 2 months later, the patient came for the outreach. He had done fairly well. And we managed actually to separate. We managed to separate the lid. And we could see that, as I told you, we had a levator muscle, and it has managed to lift our lid a few millimeters, around 6 millimeters, and it's still swollen. So he might be able to clear the pupillary axis in future and might be able to use this eye. So this is the best we could do in our circumstances that we had. So in short, eyelid malignancies are rare in our setting, fortunately, but when we get these cases, it's good to be prepared and to be able to pick them out. And because once you get them out and we get them early, the surgery is fairly straightforward. Reconstruction is not complicated. But when the lesion stays for long, then it becomes a nightmare in terms of reconstruction and achieving good cosmesis. Of course, after excision, then the lid margin, the lid reconstruction principles apply, and the reconstruction can be done, especially after the lid margin clearance has been confirmed by histology. And if you can do frozen sections, then frozen sections can be useful in this. Of course, if you are in doubt, then it's always good to do early referral when the lesion is, early referral instead of waiting until the malignancy has spread far. So thank you. That is my presentation on eyelid malignancies, especially demonstrated with the cases that I have seen in our setting. Thank you so much, and I will welcome questions and comments. Thank you.
Thank you very much, Dr. That was a quite comprehensive presentation. At this juncture, I would like to invite questions from the audience. You can either raise your hand and ask, or you can just post on the chat. Then we can read the questions, then Dr. answers. First comment is from Dr. Walia. He's saying good evening to all of us. He thanks Dr. Nyenze for having put real pictures of actual cases rather than textbook pictures. Then he goes ahead and poses a question. He's asking whether we have dedicated ocular pathologists outside of Kenyatta National Hospital. Maybe you can respond to that, Dr. Nyenze.
Thank you, Dr. Tony Walia. There was a trained pathologist. I don't know whether she had done ocular pathology or retinoblastoma pathology, but most of the cases we just use a general pathologist. In our case, I've not had a big challenge with the general pathologist because most of these lesions are like now the squamous cell carcinoma. The histology is the same as the other parts of the skin. Sebaceous gland carcinoma is the same as the other part of the body. The lesions are more or less the same. But we had a pathologist, maybe Dr. Kimani, if she's on the call, she can clarify, who was trained, but I think that pathologist trained in retinoblastoma, not total ocular pathology. Thank you so much for the question.
Maybe I can ask a question myself. You have hardly talked about radiotherapy and chemotherapy in all the cases that you have presented. Could you kindly just comment on those two aspects of management as far as lid malignancies are concerned?
Oh, yes, yes. Actually, I mentioned radiotherapy as a risk factor, not as a management modality. Unfortunately, these eyelid malignancies, the three of them, do not respond very well to chemotherapy and radiotherapy. That's why wide excision is the best option for them. But in some cases, we get very large lesions and we do palliative treatment with the radiotherapy. Sometimes I've seen some oncologists trying to do chemotherapy, but the response is usually not very good. We have seen another case of very large squamous cell carcinoma, which partially responded to radiotherapy. We use that as a degrade or reduce the lesion to a smaller size. And then after that, we did an excision. So unfortunately, the response to chemo and radiotherapy is not good. So wide excision is the main thing or mainstay treatment for these lesions. Thank you.
Okay, we have another question from Dr. Jiten Patel. He's asking, in sebaceous gland carcinoma, what determines whether to perform a wide excision alone versus a wide excision with mapped biopsies to rule out pagetoid spread?
Well, thank you for that question. Well, as I said, sebaceous gland carcinoma is quite a difficult case, and we do that especially in the type that masquerades as chronic blepharitis and conjunctivitis. Some cases present as chronic conjunctivitis, and in some cases you can't even tell where the margin is, and these are lesions that you can get even skip lesions. So in that case, you need to do mapping to know where the inflammation, the lesion is and where the inflammation is. That is in the diffuse type, especially that masquerades as blepharitis or blepharoconjunctivitis, chronic conjunctivitis.
Okay. From Dr. Mukiri, thanks you for a great presentation. And he goes on to ask, have you come across a patient with more than one type of malignancy at the same time?
For the eyelid, no, because again, remember these eyelid malignancies in our settings are quite few. So I've not seen two types or more than one type in one setting. Thanks.
Then from Dr. Shafiq Jafaji, he thanks you for a concise presentation. Then he asks, is there any role for laser treatment, or can instruments like the gamma knife be applicable in lid malignancies?
Well, there is thank you so much for this question. It's a very good question. Laser excisions can be done for for small lesions that has been done before. Gamma knife for eyelid, I have not had an experience with that. So yes, laser excision is one of the methods that can be done. But remember, very few people do in Kenya laser excision. Most of the times we do surgical excision. Gamma knife for eyelid, I do not have experience with that, so I wouldn't comment unless one of my colleagues in oculoplastics can answer that.
Any other question? Anyone with another question? Dr. I think we don't have any more questions. I take this opportunity to thank you for this elaborate presentation. It's an eye-opener for the attendees not to confuse chalazions with lid malignancies and to be more enthusiastic when they are examining patients, especially what looks like a chalazion at first glance may just be a malignancy when you invert the eyelid and look at the underside of that eyelid. I want at this point to invite Dr. Wanjiko to make any announcements from OSK that she may need to make today.
Thank you so much, everyone, for attending this CME, and have a great evening.
Okay, thank you so much, Dr. Nyenze and Dr. Mwema. That was indeed an enlightening presentation. Still, many thanks coming in through the chat. Dr. Nyenze, thank you so much for that great presentation. Our next CME will be on the 27th or the 17th of this month. And then the week after, we'll have yet another presentation through the Young Ophthalmologist Forum, to be a very interesting one. So please look out for that. The announcement from OSK is to continue paying up the dues, tafadhali. That's what keeps OSK running. Thank you very much for making time. See you in the next 2 weeks.